All right, it's 7 o'clock, so I'm going to get us started. I would like to introduce a dear friend to our chapter, Dr. David Batt. He's with IU Health Rheumatology. He's been one of our trusted speakers for our symposiums. We have many lupus patients in Indianapolis and the surrounding areas who see him on a regular basis. And Dr. Batt, thank you so much for being here tonight to first of all, talk a little bit about this virus and what you're seeing with lupus patients, and to answer questions for folks that are, there's a lot of worry and a lot of concern.
Well, Lisa, thank you very much for inviting me, and thank you all for spending some time with us this evening. It'd be nice if we could do this in an auditorium, but if we could do it in an auditorium, we wouldn't be meeting tonight this way because of the virus. So first of all, I am a rheumatologist. I am not an infectious disease physician, but actually I believe Dr. Fauci is a rheumatologist also, and many of you see him on TV every night. You're all probably experts on the virus at this point, but just to kind of get a little bit of a foundation, obviously this is a coronavirus, it's COVID-19. If you don't know what that stands, that's for coronavirus disease 19. So there's probably 18 other coronaviruses. And as you know, it's predominantly a respiratory virus that is spread by coughing, sometimes sneezing. And just as of today, everything's changing literally hour by hour. Quiet breathing in a room when you're with somebody for a prolonged period of time apparently can also pass it. And of course, it can be coughed onto fomites, which means inanimate things like cell phones and pencils and paper and desks and other places and shopping carts. So you have to be really, really careful because the virus can stay on these areas for a period of time, anywhere, I think, from 12 to 36 hours or so, depending upon what the product is and what the temperature is, that kind of thing. So in terms of precautions, I think we all should be practicing the social distancing, staying at home as much as possible. If you don't have an essential job, stay at home and do it from home. If you have an essential job, if you can do that from home, try to do it. Go out to the market, go out to the pharmacy, those kind of things. Try to keep going out as minimal as possible, at least for the next 3 weeks or so. I personally feel that we should have these social distancing factors in place in all 50 states. Right now, I think as of today, it's something like 40 states. Obviously, Indiana was one of the actually earliest to do it. I think we were the 17th or 18th, something like that. And I think hopefully within a couple of days, all 50 states will be following these guidelines. To be really honest, I think we're going to be doing these guidelines not through the end of April, but probably through mid or even the end of May. That's just my feeling after reviewing the data that's on the internet from China and Korea and these other places where they had their apex, and then it took a while to come down the other side. So with that as a backdrop, the question obviously is, what's the difference and what are the significance in patients with lupus? So there are several things that we have to deal with lupus. First is having the disease itself, which, as you know, is an autoimmune disease that has immune dysregulation, which means, of course, that your immune system does not work that well. It looks at you as the enemy and attacks parts of the body, but it also, you don't respond that well to vaccinations and don't respond that well, and there's obviously an increased incidence of infections in general in patients with lupus. So right there is an underlying immune problem that you have to be aware of. The second, of course, is the double sword of the medications that we use. The medicines that we use dampen down the immune system so lupus doesn't attack the body. But on the other hand, when you dampen down the immune system with the drugs that we use, you increase the risk of getting infection. And many of these drugs you're very familiar with. We use Plaquenil, which actually has a very mild immunosuppressive effect. It's not really a major player in that regard. So that risk itself is not as large as some of the other medications. Steroids are the big one, and anything more than 5 milligrams a day or more is probably put you at a higher risk. Immunosuppressive drugs like methotrexate, which we use, drugs like azathioprine, Imuran, which we use, leflunomide Arava, which is sometimes used in lupus. A big one that we use is mycophenolate, which is Cellcept. Some people receive Benlysta infusions or Benlysta injections. Some people receive Rituxan. Some people receive cyclophosphamide, which is Cytoxan. So there are lots of drugs that patients receive. And then the third part of this triple header, so to speak, is that patients who have underlying organ damage, heart disease, lung disease, kidney disease, are also at a higher risk. And some of you patients with lupus have organ involvement from the lupus itself. And sometimes you have comorbid conditions, which means that lupus resides with a person in addition to other conditions. Lupus doesn't protect you from heart disease, from diabetes, from renal disease, from pulmonary disease, asthma, COPD, those kind of things. So it's kind of a trifecta here of the underlying disease, the medications that we use, and then the organs of the body that can be involved either from the disease or from comorbid conditions. Now, speaking of medications, one of the questions that I have been asked, if not once, 500,000 times in the last week, is what about my Plaquenil? So here is my take on Plaquenil, and you have to realize there is no edict that has come down from the American College of Rheumatology, nor the Lupus Foundation, but in talking with my colleagues and doing the research, this is the data on Plaquenil. When Plaquenil is in the body for several months, a steady state is called. When you stop it, the half-life, meaning that half of the drug is gone in a certain period of time. So if the half-life, say, is 2 days, half of a drug is gone in 2 days, then another half of the half, which means a quarter is left, and then a half of that, which means an eighth is left every time you do a half-life. Plaquenil has a half-life of 21 to 28 days. So we're talking about 3 to 4 weeks. If you stop Plaquenil on April 1st, on April 20th or so, you still have half the Plaquenil in your body. If you then go to May 10th, you have about a quarter of the Plaquenil in the body. If you go to June 1st, you have an eighth of the Plaquenil in the body, and so forth. And the studies show that over a period of 3 months, all the Plaquenil leaves the system. So it means that if you stop it, you're not going to have a flare of your lupus in the next couple of days or couple of weeks or even a month or so. And to be really honest, I've had many patients over the decades, notice how I say decades, not years, who have stopped their Plaquenil for multiple reasons. They didn't want to take it. It might have been too expensive. Their eye doctor said they shouldn't take it, so they stopped it. They got lost to follow-up. And even after the Plaquenil is out of someone's system in 3 months, I've seen many patients who took 6 months to a year to even have a flare of their arthritis or their skin disease or whatever. And some patients, it never happens. So I don't want you to think that if there's a shortage of Plaquenil and you're without it for a week or two, you're going to have a flare. Now, there's 2 other things. Number one, many patients with lupus are not living in a bubble where the only thing they're on is Plaquenil. They may be on some low-dose prednisone. They may be on Imuran, methotrexate, mycophenolate, Rituxan, Benlysta, cyclophosphamide. And in terms of the strength of affecting the immune system, Plaquenil is a much, much, much weaker drug on the immune system than these other drugs. So if Plaquenil is stopped and the other drugs are continued, it's very unlikely that one will have a major flare of their lupus. The third thing in regard to Plaquenil is what I'm telling my patients, and my partners and I are doing this. Again, there's no science behind this, but if you're taking 200 milligrams twice a day and you get a 90-day prescription and you have 180 pills, I'm telling people if they're on it twice a day to maybe take it once a day. Or if you're on it once a day, take it every other day. Or if you're really in a crunch and you only get 60 from your pharmacy, take one every other day. The math tells me that 60 pills taken every other day will last you 4 months. That will certainly, I feel, get us through this crisis situation. The crisis is because, as you know, a lot of people are taking Plaquenil or are trying to take Plaquenil to treat the COVID-19. There is no absolute scientific evidence that the medication helps. There are some studies in test tubes in cells that Plaquenil reduces the replication or doubling time of the virus growing in the body. There are some studies where Plaquenil is being given at 800 milligrams, which is twice the normal dose for people admitted to the hospital for like a day, and then they're given 400 milligrams a day for a few days. Those studies are still being done. There are also some studies using it long term. But again, there is no science behind it at this time. So we will see whether that pans out or not. The second thing is, and my understanding from talking to my friends in the pharmaceutical industry, is that as the years have gone by and Plaquenil has gone from a branded name drug to a generic, there are very few companies, pharmaceutical houses, making it. And I think many of you have noticed in the last few months or so, even before this, that the price of Plaquenil has gone up because there have been less people making it. So I was told recently that at least 2 other companies, maybe 3, have just started ramping up to make the drug. So there will be more of it because of that. The fourth mention I have on Plaquenil is that I have patients who have difficulty getting it from their pharmacies here in Indianapolis and other places here like Caremark, et cetera, OptumRx. I am suggesting that you go online and look at Canadian mail orders. There's one in particular called RX Connected, which my patients have been using, and another one called CanDrug, which my patients are using. But if you go online, I think there's about a half a dozen Canadian mail orders. They usually require 90 days at a time, which is usually not a problem. The other thing that I have noticed in the last 24 hours, as my patients have called for refills, is that pharmacies are asking that a diagnostic code be placed on the prescription, either a diagnostic code for lupus or a diagnostic code for rheumatoid arthritis. And without those codes, they will not provide the medication. A lot of pharmacies also will continue to give Plaquenil to patients who have been receiving Plaquenil for a number of months, if not years. So they're kind of grandfathered and grandmothered in. But if out of the blue, Joe Blow asks for a quantity of Plaquenil and has never received it, they're not giving it to somebody because they're assuming that it's probably not a patient with rheumatoid arthritis or lupus, but just someone trying to bend the rules, so to speak, and just get it and hoard it for their own consumption. So these are all things that I've noticed. Some of this is very fluid. Some of this information is literally 24 hours old, such as requiring the prescriptions to have the diagnostic codes on it. Again, just within the last couple of days, I've heard there are more companies making it. And I think that we're also going to find, and you need to watch Dr. Fauci on TV, we're going to find out very soon whether the medication is actually effective or not. I don't know if it will be. We're just going to have to see what the studies show. I believe that was all I had in my prepared remarks, and I see there are 15 chat questions. So Lisa, maybe we should start getting to some of those.
Okay, so the first question I see is, what additional precautions should I take during this pandemic other than my usual precautions?
You know, the precautions are exactly what the CDC says. Do the social distancing, stay home as much as possible, wash your hands carefully after you've been out. One that actually started literally, well, may start tomorrow, this idea about the masks. You know, I think in a perfect world, if we had 100 million masks, 330 million masks, actually 500 million masks, because healthcare workers need to change them every day,
Yeah.
then everyone should wear a mask. But if you are wearing a mask, and that takes away from the supply for a healthcare worker who's taking care of a sick patient in the hospital, and that healthcare worker gets sick, then that takes a warrior, if you will, out of the flow. I think that it doesn't necessarily have to be the N95 mask. It probably doesn't have to be a surgical mask. I heard someone the other day just talked about using a bandana and kind of look at Jesse James robbing. So I will tell you, if you do a bandana, don't go into your bank. Call the police. But anything that is a barrier to the droplets. And a week ago, again, this changes on the fly. A week or so ago, it was felt that the only way you got it was from a cough, meaning the particles would directly spread to you or to something that you touched. Now there's some thought that there might be what's called aerolization, where with aerolization, the viral particles can stay in the air for a period of time, and someone can cough or breathe into the air, walk away, and a few minutes later, you go into that space and inhale it. So I think that if you can get creative with some masks that are not, and I don't think you need to run out and get the N95s, you need to save that for the healthcare workers. But
Right.
Just simple surgical masks, or like I said, even something homemade like a bandana, I don't think that would be a bad idea. Again, the science is not completely there yet. Dr. Fauci thought about this the other day. He's leaning towards it, but he didn't say it's something you need to do. Again, we have to play off the resources of how many masks are going to be taken away from healthcare workers and police and firemen and EMS people that may not be necessary to be used by the population in general. But my point is, if you have access to some kind of barrier, my recommendation, again, I'm only a rheumatologist, I'm not infectious disease, I'm not Dr. Fauci. I would say if you have access to a mask, it wouldn't hurt you to wear it when you're going to be in a public place, such as the grocery store or the pharmacy, or if you have to go and pump gas for your car and there's some people around. I would probably err on the side of maybe doing that, but not running out and trying to order N95 masks and take those away from healthcare workers.
Someone is asking, is it okay to take, and it says ester C to boost immunity?
To take ester C to boost immunity?
Yes.
I don't know much about ester C, but I want to tell you something. Again, this is the plight of people with lupus. You do not want to boost your immune system too much, because then you could have a flare of your disease. Remember, what we do to treat lupus is to dampen down and downregulate the immune system. And I know in years gone by, when people were taking things like St. John's wort and all this other stuff, they actually saw patients with lupus and other autoimmune diseases actually worsen. So I don't think something like ester C is going to be a big problem. I don't really know if it'll help or hurt. But I really think just routine multiple vitamins and practicing the social distancing is what you really need, not pumping yourself with a lot of over-the-counter stuff.
Got it. Do we have any more questions, either in the chat room or in the Q&A section of the screen? There's no such thing as a stupid question, and we have Dr. Batt and wisdom. So I would encourage you to send questions in, and I will read them as they come.
I see 15 in the chat queue.
I can't see that many.
Huh.
I see where they're from. Q&A.
Oh, I see one now in the Q&A.
Christine says, no questions. Thank you for doing this. If you can see any in the chat room.
Let me see if I can click on these. Wait, hold on. Let me click on chat. I think a lot of those chats were just where people were from.
Right, right.
Let's see. Yeah, I think that's just a lot of people saying where they were from.
Okay, so we do have one question here, and it's how long can we expect social distancing?
Boy, I wish I knew the answer to that. I will tell you, you know, the federal government has decided through the end of April, but if I were a betting person, I would say that we're probably talking through Memorial Day. I think a lot of it depends how quickly we get to the top of this apex, the curve. You know, most of the epidemics and other pandemics that have occurred in the past with viruses and other things is that, you know, they shoot up to the apex and they go up fast, but they don't necessarily always come down at the same rate that they go up. It's kind of a big curve on the other side. So, you know, if we get to the top of this by mid to late April, I don't think we're going to be to the bottom of this by late April to the first week in May. I think it's going to be closer to Memorial Day. And I'm really expecting most places to say the end of May. And then the thing on top of that is that the data on patients that may succumb to this is all based on the whole country kind of batting down the hatches and doing the social distancing for a period of another 4 weeks. And I think as of today, there were still at least 7 or 8 states that were doing this. And the problem is that, you know, even if most of the states do it, if some states don't, then there's going to be more action, so to speak, in those with prolongation of the pandemic. So I kind of liken it to taking a bandage off. It's better just rip it all off at once and get it over with than peel it off slowly. And having this very slow mandated social distancing in different states without just kind of doing it all at once seems to me like the slow Band-Aid tear instead of a quick rip. But that's just my personal feeling, and I believe Dr. Fauci and Dr. Birx and the other people, Dr. Birx and the others all have that same feeling.
Right, right. We're getting a lot of questions now. What about visiting with extended family if it's 6 feet away?
Well, again, the thought is, this is what you have to assume, since it can be asymptomatic. You have to assume, for the time being, that everybody you come in contact with has the virus, and that you have the virus and you're asymptomatic and you may be spreading it. So again, what about visiting an extended family if at least 6 feet away? Okay, if you're 6 feet away and that person is not a high-risk person, which by definition at least is somebody a little older and someone who has comorbid conditions, although I will parenthetically tell you that there was an infant that died recently, and a lot of young people get it too, that probably would be okay. But again, you should not get together in a large group.
Mm-hmm.
And my thought is this, just like what we're doing now with the Zoom, if you're going to visit an extended family member and you're going to be 6 feet away at least, it makes more sense, I think, to visit them by Skype or visit them online. You're not going to give them a hug. You're going to do a virtual hug from 6 feet away. To me, it's safer on a computer from your own home. So you can do it, but in a perfect world, I'm trying to think, why would you want to take any chance? Because part of visiting the extended family member is probably driving to that person's home. And so being out and about when you don't have to be doesn't make a lot of sense to me.
Very good. Kathy wants to know if being on Plaquenil offers any additional protection against COVID-19.
Nobody knows. In fact, it was just mentioned in a conference today that would people who have chronically been on it have less risk of getting the virus or less risk of getting a severe response to the virus? Nobody knows.
Okay. Jury's still out on that one.
Correct.
We have another one. I work in a pharmacy and I'm not waiting on customers at counters. How long do you feel would be a good time length to stay back?
Like stay back behind, not getting into the counter area,
Right, right.
back room, filling prescriptions or something.
That's my understanding.
Yeah, I would do that through this entire time of social distancing, which is at least going to be to the 1st of May. It might actually be till Memorial Day or later, who knows? But I would just do the social distancing and just, again, make the assumption that anybody that walks into your pharmacy may have the virus. You want to stay, even if they're asymptomatic, you want to stay 6 feet away or at least or more. And I would say if you have lupus and you work in a place of essential need where the public comes in, that would be a situation where I would say I would wear a mask if I were in your situation where there's a lot of foot traffic to a pharmacy, especially the fact that in general, people that come to a pharmacy need drugs and people that come to a pharmacy are sick. So some of those people coming in may be coming in for cold remedies and other things who think they just have the flu or a cold and they might be COVID-19 positive. So my thought would be that a percentage of people that walk into a pharmacy might be more likely to have the virus than the percentage of people that walk into your local grocery store. I may be wrong on that, but just thinking ahead of looking at demographics, if you're in a pharmacy, I'd be in the back, or I'd wear a mask, or I'd even ask the head pharmacist or the owner of the pharmacy, whatever, whether it's CVS or Walgreens or wherever, if you have even though it's an essential establishment, if it's something that you could do from your own computer at home, I would recommend that if you're in the pharmacy business. But again, I'm just speaking from my personal opinion on this. Again, the science changes every day, but just based on what I have read, and I've kept up on this every day for the last 6 to 8 weeks, if I were working in a pharmacy and I had lupus, I'd stay in the back, I'd wear a mask, and I'd ask if I could work from home if possible.
Thank you. Okay, you see the next one? Do you think?
Yeah, do you think it's in the air? So
Yeah.
just as I said, originally the studies were that if you coughed, that it would go up to 6 feet and then basically disappear, just the droplets of moisture droplets with the virus. Now, just in the last 24 hours, it's been said potentially that this could be aerosolized. I don't know why I can't say that real fast. Could be aerosolized. And so someone could sneeze or cough into the air and walk away, and it could hang in the mist for a period of, I don't know, several minutes or even longer. So when you say in the air, yes, in that respect, but if you go out for a walk or to jog or stroll or something, it's not going to be, in the air that the virus is laden in the air and you're going to get it breathing. You would have to be close to somebody or within a moment or two or three or four, or whatever, of them coughing or sneezing into the air, pass through that mist. So I don't want people to get the idea that going outside to exercise is bad. I think that's good for a couple of reasons. If you stay physically fit, you're more likely to not have a flare of your disease. You're also going to be, by exercising, you're going to get reduced endorphins in your brain. You're going to feel happier. You're not going to have as much anxiety. You're not going to have as much depression. You're not going to have as much cabin fever. So I really encourage everyone, if they can, to go out and do some walking or jogging or whatever exercise they like. I don't think people should just stay inside and be couch potatoes. So it's not really, quote, in the air all around us. It's just selectively in small pockets if someone has just coughed profusely and then walked away.
Got it. Lots of information concerning the use of NSAIDs.
NSAIDs versus Tylenol being
Yep.
preferred. So I think that comes from the fact that in many other viral illnesses, especially in the pediatric age group, there has been some liver involvement, and nonsteroidals can affect the liver. Nonsteroidals also can affect blood pressure. Nonsteroidals can affect your heart. Nonsteroidals can affect your stomach. So there are more potential side effects of nonsteroidals. In relatively moderate doses of 3 grams a day or less, Tylenol is a very, very safe drug that doesn't really have any of those things. Yes, in very high doses, it can affect the liver, but in low doses, it doesn't. And I think a lot of this came from a disease called Ray's disease, which was a viral illness, I believe, in the pediatric group years ago, where they found that kids that took nonsteroidals had more problems. Again, I'm not an epidemiologist and I'm not an infectious disease doctor, but I think in some of the other viral illnesses that have been around, I don't know whether it was the Zika or some of the others, I think they found steroidals might have caused some more problems. So a lot of the infectious disease experts are suggesting that people should probably take Tylenol rather than ibuprofen. Tylenol is excellent bringing down fever. So is low-dose ibuprofen. But ibuprofen and naproxen and those drugs are really more anti-inflammatories that take, several weeks to build up in your body. So for strictly pain and fever, I personally take Tylenol and don't take NSAIDs. So I think there's a number of reasons why I think the authorities who are experts at this have suggested that maybe Tylenol is better.
Okay. If Plaquenil is used to treat COVID-19, what else would work for us as lupus patients?
I assume that question is if the Plaquenil supply would dwindle and there
Right.
wouldn't be any available. That's what I'm assuming. So Plaquenil is very, 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 did I say very several times, mild drug for rheumatoid arthritis.
Mhm.
Actually, most of my patients with rheumatoid arthritis are taking methotrexate and biologics. And so if your disease is so mild that all you're on is Plaquenil, then if you're off the Plaquenil, as I said, it could take 3 or 4 months to get out of your system. You probably don't have severe rheumatoid arthritis. And if you're taking Plaquenil in addition to methotrexate and or a biologic, again, it's a milder drug on the immune system, and stopping it, you probably wouldn't notice much of a flare. If we go to the lupus patients, it's kind of like if you're not on Plaquenil, then the next step is usually stronger medications. You have to go to low-dose steroids, which in themselves can cause some problems. drugs like methotrexate, Imuran, Benlysta, Cellcept, those things. So a lot of it depends on what organs are involved in Plaquenil, in lupus for the Plaquenil. I use Plaquenil as background medication in every one of my lupus patients unless there's a contraindication, because the studies that have been shown out of Johns Hopkins by Michelle Petrie and others is that if you look at thousands of patients with lupus over a period of decades who take Plaquenil, and thousands of patients with lupus over the decades or so who don't take Plaquenil, those that don't take Plaquenil don't do as well. But that being said, and I said this at the outset of our discussion, most of my lupus patients are taking more than Plaquenil. They're on 2.5 to 5 milligrams of prednisone. They're on Imuran. They're on Benlysta. They're on Cellcept. They're on methotrexate. So again, withdrawing the Plaquenil for a period of 2 or 3 months is probably not going to be a problem. And stopping Plaquenil completely in some of these patients, if you're on other things, is not going to make a difference for a longer period of time. And also, as I mentioned, if you have a small amount of Plaquenil, probably taking 1 pill every other day will probably be enough to get you through this pandemic.
Okay. And then a Cellcept question. I'm on Cellcept. Should I stop it if I get sick?
So you need to do with Cellcept what your rheumatologist says. I can't make a statement there because Cellcept is sometimes being used for patients who have renal disease, serious pulmonary disease, cardiac disease, and other things. What I usually do, and I tell my patients if they're on methotrexate, if they're on Cellcept, if they're on azathioprine, if they're on Benlysta, if you have an infection and go on an antibiotic or have a serious viral infection like the flu, I usually have them hold it for about a week while they're on an antibiotic, say it's a bronchitis, and or sometimes reduce the dose in half for a couple of weeks and then go back to full dose. It could potentially be very dangerous if you develop an infection to stop Cellcept completely for a prolonged period of time. So you have to say, well, why am I on it? What's my dose? And when I get sick, getting sick is a relatively vague statement. Is it a high fever, 102? Is it just having the sniffles? So these are things that you need to discuss with your rheumatologist or whoever has you on the Cellcept. So it really can give you a blanket question. You should never stop it without checking with your rheumatologist or pulmonologist or nephrologist or neurologist or whoever has given it to you without discussing it with their office first.
Okay. I am going to hop into the Q&A section right now. Is it okay to have my bi-weekly housekeeper clean if she is only cleaning immunosuppressive homes and says she is socially distancing at home, and if I stay 6 feet away from her?
Wait, I'm sorry. I'm reading a different one. It says, I have asthma, taking mine. Are you on a different question?
Yes. You can.
I'm sorry.
Go ahead and address the asthma one, and then I will open it up to the Q&A part.
Okay. I have asthma also. Taking my inhaler, still okay this time. I've never had signs of asthma, but I'm doing my inhaler. Makes my throat dry. And these are questions about your inhaler you need to discuss with the doctor that prescribed the inhaler. I don't prescribe inhalers, but inhalers sometimes can dry out your throat a little bit. That would be something you need to discuss with the doctor that prescribed it.
Okay. Thank you, Dr. Batt. So I'm in the question and answer section part now.
Okay.
She's asking if it's okay to have her biweekly housekeeper clean if she is only cleaning immunosuppressive homes and says she is social distancing.
Well, that's a tough one. I would not think, my wife will disagree, I would not think that having a housekeeper come in is an essential part of business right now.
Right.
And if someone who's going to different homes, one never knows whose path they're crossing. So as part of social distancing, I would make my home my castle and basically bolt it shut as much as possible with as few people coming in as necessary. So I guess personally, I wouldn't have a housekeeper come in during this period of time.
Is it okay to have a glass of red wine when on Plaquenil?
Absolutely.
Okay. Somebody's happy with that answer. as we've already addressed, being on Plaquenil and whether or not we know that offers any additional protection. We don't know the answer.
We do not know.
Right. We don't know. Should lupus patients be more cautious until a vaccine is available for the virus?
I think the answer to that is yes. Most of the infectious disease experts feel as a respiratory virus that this may start to wane as we get towards the early to middle part of the summer, but it may come back next year. So we go through all of this again next year. The experts say that a vaccine may be out in a year, so that would not really help us in the 2021 winter. Now, one thing that does happen with viral pandemics and epidemics is that there's an entity which is called herd immunity, which means that a lot of people get the virus and get over it. I mean, let's face it, 99% of people that get this virus, 98.5% of people that get this virus live. The other people that get it have a mild disease, sometimes a protracted course, and need hospitalization, and many are asymptomatic carriers. And unless this is different from other viruses, one develops antibodies to it, which is basically like a natural vaccination. So this year, let's say 0% of the population had any antibodies to it. Next fall or winter, it could be that 30, 40, 50% of the population has antibodies. So if a lot of people have antibodies, it's a lot harder to transmit it. So what I'm saying is, whatever the peak is this year, if this comes back next year, and there's no reason to believe that it wouldn't until we get a vaccination or something else changes, the peak next year will be lower than the peak this year. But until there's a vaccination, we have to be aware of it. You know, an interesting point about vaccination, 35 to 37,000 people die every year from the flu in the United States. And if you look at from mid-September to mid-March, that's 200 people every single day. And we have a flu vaccination available. And I would dare say that half the patients that walk through my office don't want to get a flu shot. So you have to remember, even if the answer is there, a lot of people don't take advantage of it. And there may be many patients when we get a COVID-19 vaccine who are going to not want to get the vaccination. And I thoroughly implore everyone to get it, especially if it's a dead vaccine, a dead virus, which it probably will be. Because remember, a lot of people, my rheumatoid patients, my lupus patients who are taking biologics should not get live vaccinations. But assuming that this is a dead vaccine, I encourage all of you to get it.
Great, thank you very much. Have you heard of anyone with lupus contracting the virus yet?
I'm going to knock on wood. None of my patients have gotten it yet, or at least nobody's called me. But remember, where I am in Marion County, in Indianapolis, there are only, I think, 400 cases in the county right now. So it might be too early to tell. I'm sure patients may have it, but they're asymptomatic, so they didn't get tested.
That's true too, right? Right. Is it okay to reuse your mask?
I'm sorry, is it okay what?
To reuse your mask.
To reuse your mask. So I think it's a lot different for the normal population as to the healthcare workers who are in front of patients all day long. I think if you have a little surgical mask and you're doing self-quarantine or social isolation, social distancing, and you go to the store, I'd put the mask on. And then when I got out of the store, I'd put it in my car and drive home. Then if I go to the pharmacy, I'd put the mask on. And then when I get it back to the car, I'd take it off. Because again, you're assuming that people you come in contact with might have it, and you're assuming that you might have it. And I think any kind of barrier which reduces the spread, especially if the data that just came out literally in the last 24 hours is that someone even with quiet breathing, without fever and without coughing could spread it. I think any kind of barrier protection like that would probably be okay. I don't know any reason why you would have to change it immediately. You know, healthcare workers, I'm concerned that they're wearing the mask, the N95 mask, in a room with someone with COVID-19, and then they go into a room of another patient that doesn't have it. they can't change masks because there aren't enough. I mean, ideally, you change a mask every time you go into a room with a different patient. That's universal precautions that we've been taught for 40 years. But kind of all of those things are out the window right now because of the lack of personal protective equipment. But I think for the average person who's not going to be going into that kind of environment, I don't think there's anything wrong with reusing a little mask. Or again, why not use a bandana, look like Jesse James, and then after a day or two, go home and wash it and wear a different colored bandana.
Just avoid the banks.
I'm sorry?
Just avoid the banks.
Yes, just avoid the banks because they'll call the police.
Do you think it's fine, Dr. Batt, to go through drive-through restaurants?
I don't think there's anything wrong with that. What I would do is this, you know, you order, you open up your window and you order, and then you go and you give them some. Here's what I would do though. If you go somewhere and it's $1.97, don't take the 3 cents change. Just let McDonald's. And then they'll give you the bag. They're usually wearing gloves. Then what I would do is this. I would take the bag, and of course they're wearing gloves, but they might have touched some other people. You never know. What I do is I go through the drive-through. I like Taco Bell, and I like Arby's and McDonald's. I like an Egg McMuffin. What I do is I take the bag, and then what I do is I go home and I pull into my garage. And when I'm there, what I do is I take out my little Purell, or I take a Clorox Clean and Wipe, and I take in the bag, I wash my hands, I wash the steering wheel, I go in and I wash my hands. And so any possible contamination is washed away. So I like to think of my car as also my safe little semi-castle that moves around. But yeah, I think that's probably good for your psyche too, because everybody cooking every night forever, they're going to go nuts.
Yes, I can agree with that. And I'm not the best cook, so because of our compromised immune system, say during this quarantine, we end up getting a sinus infection or bronchitis, and not COVID-19. How will we be able to do treatment since we can't be near a hospital or clinic?
About getting something like a bronchitis?
Or a sinus infection.
All right, so right. So we're doing since basically St. Patty's Day, we are doing all of our visits virtually or by phone. And if I have a patient who's immunosuppressed from their underlying disease or the medicines I have them on, and they call me and they tell me they're running a fever and they have a bronchitis and they're bringing up green sputum, which would not be what you'd see with COVID-19. That's a dry cough. Or they have a sinus infection, or they have a urinary tract infection or something. I'm not making them come into the office. I'm just phoning in an antibiotic for them and saying, listen, the antibiotic takes care of it, we're done. If the antibiotic doesn't, then maybe you need to come see me. I do a few urgents, or you may need to go to an immediate care center or somewhere like that. I would definitely stay away from hospital emergency rooms for 2 reasons. They're overloaded. And number 2, that's where the COVID-19 patients are. And so they're in that environment. And that one person said, is it, quote, in the air, unquote? Well, kind of in a euphemistic way, it is in the air in hospitals because that's where all the patients are going. So I'm saying that facetiously. It's not really in the air, but there's a lot of people there with it. Right. So I would go to other places and I'm trying to do as much care of my patients for urinary tract infections and bronchitis and sinusitis and even flares of their disease over the phone or by a virtual visit, and not subjecting them coming into the office or having to drive unnecessarily.
Got it. Someone in the chat room says, or in Q&A, my wife takes Plaquenil, sulfasalazine, and azathioprine. Yeah,
so that's Plaquenil, it's azolfidine, and it's Imuran, and that's a common combination. Well, not. It's one that's used. It's used for rheumatoid arthritis a lot. Okay. That's what she's taking it for. And what is the question about it?
She's just asking how the doctor determines which drugs to put her on.
Well, I mean, those are, that's not for this discussion. That's a
Yeah.
question for that patient and that doctor to make a decision about what treatment program they're going to use. We used
Got
to
it.
use a lot of Plaquenil in rheumatoid arthritis. We used to use a lot of azulfidine. We used to use a lot of Imuran. We tend more to use methotrexate and biologics now, but there are patients where those drugs are contraindicated because of kidney disease or liver disease or lung disease or other infections problems or other diseases like heart disease and peripheral neuropathies. So azulfidine, methotrexate, and Imuran is a combination that some people use. Azulfidine is not as commonly used as it used to be, but is still used in some patients. But that decision was between this patient, this person's wife, and the doctor, not anything that I can really comment on.
Got it. And then I may have misread a question earlier, but for clarification, the prior question about Plaquenil was actually asking that if they do get COVID, but they already have Plaquenil in our system, would it work for them as a treatment at a higher dose?
Again, nobody knows. There's studies that are being used. The problem is if you increase the dose of Plaquenil, some of it's based on your weight. And if you take too much of it, you can get eye disease, you can get muscle disease, you can get cardiomyopathies. Plaquenil is not totally innocuous. So again, I would not be taking higher doses of a medication that has not been proven to treat another disease because you could potentially get into serious problems. And then of course the eye toxicity, which is irreversible, is something that can be seen if you're on the wrong dose based on your weight. There is no data at all in rheumatoid arthritis and lupus data of taking more than 400 milligrams a day. And there's lots of data that in people under 135 pounds, basically 65 kilograms, should be on no more than 200 milligrams a day. So I do not know what happens if you would take somebody who's a normal weight person and put them on 600 or 800, because there's absolutely no data what that could cause in terms of potential side effects. And as of this moment, there is no data that it's helpful. So wait and see what the studies show. As I tell my patients, let somebody else's patients be the guinea pigs. I don't want you to be the guinea pig.
Very good. Is it safe to say that if you do get the virus, everyone in your household will get it too?
Not necessarily. It's not 100% penetration. I think if you have group hugs every night and cough on each other, yeah, then probably you all would. But if you're doing social distancing and you're not sharing the same equipment and knives and forks and that, and you're in a different part of the house, there are some situations where it's been suggested that if someone, say, who's, let's say, 35 or 40 years old gets it, who's healthy, and they have an 85-year-old grandmother with lung disease in the family, maybe the grandmother should go live somewhere else, or maybe that person should stay out of the house, and especially, you know, that kind of thing. But it's not 100% communicable. The longer you're in contact with somebody less than 6 feet, and especially if there's coughing or that kind of transfer through the air or transfer through a fomite, meaning something that you touched that they then touch while the virus is still alive and active on it, then you could get it. But it's not 100%. But I would definitely quarantine myself to another part of the house. And also, you know, talk with your personal physician about that and discuss the other people in the household and decide whether they think that maybe you or they should maybe be living somewhere else temporarily.
Right. One question is it true that the virus lives on clothes and hair?
That the virus what?
Lives on clothes and hair.
You know, I don't know. I can't answer that. I know that there were studies that done that different substances, it lived longer, you know, cloth versus metal versus wood versus, but I don't really know the answer about how much. I mean, I know that the emergency room physicians at our hospital, when they come home, many of them will just take and strip off all their clothes in the garage. And then this is an interesting visual, strip off all their clothes and run naked through the garage, through the house to the shower. And then when they get out of the shower and put on their regular clothes, they come out and see their family. So I'm sure that it can be on clothes and those kind of things. As to how long it lasts, I don't know. As to how long it lasts on hair, I wouldn't know much about hair. Well, they can't see me, but I don't have much hair. I don't know the answer to the hair thing. That would be something you'd have to probably ask some expert infectious disease doctor. I just don't know about hair.
Okay, and then we have one that's not necessarily a lupus question, but a rheumatology question, she said. She takes Stelara, but stopped taking it in January due to a shingles vaccine. Should she consider
I'm sorry, it got all gobbled.
Okay. She says, I take Stelara, but have stopped it since January due to the shingles vaccine. Should I consider staying off of it for the next few months to avoid suppressing my immune system?
Okay, so Stelara is usually taken every 3 months. So it's still in your system. And what I've done with a lot of my patients who are stable, so this is probably someone that has psoriatic arthritis, if they're on Enbrel, or if they're on Humira, or if they're on Cimzia, or Golimumab, which is Simponi, or Stelara, or Cosentyx, if they're concerned about exposure, I've told some patients to kind of spread out their shots. So if Enbrel, I have them spread out from every week to every other week, or if they're on Benlysta shots every week, I spread them out to every other week. So Stelara would be every 3 months. You know, she took it in January, she's due again in April. If your arthritis and if your psoriasis are not super bad, I don't think there'd be anything wrong with maybe trying to wait till maybe the end of April and just lighten up a little bit on your immunosuppression. I doubt that you'd have a major flare. But again, that might be something that you would want to discuss with your personal rheumatologist before doing it.
Very good. Well, unless we have any more questions, I think we've gotten through all of them.
Yeah, that's good because I don't have any more answers.
You did. You were fantastic, and I can't thank you enough for joining us tonight. Well, I've got you like on the hook. Maybe you'll join us again in a week or two, and we
Absolutely. And again, I want to put out my plea to everybody there. You know, stay inside, go out minimal if at all possible, wash your hands a lot. Remember, you know, you may not have the disease, or if you get it, it could be mild, but you'd hate to transmit it to a friend or a family member who could have a really serious reaction to the virus. And again, it is not innocuous. The death rate, I think, in the world is about 4.5 to 5%. The death rate in the United States right now is running about 2.5%. I think it'll go down as the amount of patients who have the disease goes up. So as the denominator goes up, the amount of people that have it, the numerator, which is the amount of people that die, will probably go down. But I think in the long run, when it's all said and done, we're going to be looking at about 1 to 1.25% death rate. And to give you some context, the regular flu is about 0.15 to 0.2. So this is about 5 to 6 times the death rate, and it's about 2 to 3 times as contagious as the flu. And that kind of puts things into perspective. So just be really careful out there and just do the social distancing.
We will do it. We hope you can do it too, as much as you possibly can, being a physician and putting yourself on the front line. Dr. Batt, we appreciate you very much.
Well, thank you very much. I appreciate it.
You stay safe.
Tuning in tonight.
Okay, thank you.
Bye-bye.
Bye-bye. Thanks for joining us, everyone.